And welcome back to Roland Bones, the Osteopathic Podcast, with your hosts, Dr. James and Dr. Dante, continuing on that wonderful, engaging healthcare discussion. We've talked about the history and the current status of the American sick care system, because we've established it's not truly a healthcare system, but we have to figure out how to change the system so it can be truly a healthcare system. Now, you all know that we're a couple of osteopaths. We've well established that. And in some of our episodes, we talked about some of the things that Dr. Still and others did early on, especially Dr. Still and the sanitarian movement from the early 1900s. I think it's interesting that we've gotten away from that model where you just, if you want to heal the patient, just bring them inside, hang on to them for 6 months, feed them good, exercise them good, and then set them free. We have some wellness clinics out there and medical spas and whatnot, but it's not the same. So the question we are going to deliberate on, we're going theoretical today, is what in the heck do we do different? And should we do things different?
So I guess before getting too deep in that, we'll set some context and ground rules, since this essentially amounts to a weird theater of mind game between the two of us now, right?
Exactly.
So important things. We are actively trying to play with what it would mean to make a new system. At the same time, this is actually not to denigrate or otherwise put down the current system. For all the things I genuinely don't like about it, I actually had 2 college students shadowing, as in following me around today, and I kind of laid in about all the ways the system is broken, because it is quite bad. There are things it is genuinely good at. For example, I think that our current system trying to provide healthcare is a problem, but our current system is excellent at delivering sick care, right?
It does. It saves lives. And when we talk about the system, if we talk about the system as though it's broken, that assumes that it was working well at some point. And so maybe we need to reframe this discussion into a system that's not working well for everyone. And how would that system look if it were? What does it mean to be working well for everyone? What would the goals be? Now, we face some uphill battles in this whole discussion. I recently listened to a podcast on the FinTech podcast, which I highly recommend that podcast if you want to hear more about financial discussions. But they talked about healthcare in the industry, and that there is a mismatch of incentives between providers, aka physicians, payers, which are the insurance companies, and the insurance companies, the providers, and the patients. Drawing a blank on the third P, which is the most important P of that group, because insurance companies,
providers, payers, patients,
and patients.
And for those who aren't as familiar with the lingo, payers is our category that we use to describe the insurance companies. They're also referred to as payers because at a technical level, they're the ones who quote unquote pay for our services.
Well, I joke that it's the golden rule. He who has the gold makes the rules, as you know from Aladdin. We got a Disney reference in there for you.
Took us all of what? It's been 5 minutes, not even?
Not very long.
All right. So we got Still and Aladdin.
Yeah, Still and Aladdin, all in almost the same breath.
But yes,
the payers have. That's right. The payers have an ethical obligation to their shareholders. Their whole model is to produce income and profit for their shareholders. So from a business standpoint, it makes sense for them to enact policies that will pay as little as possible so that income can be returned as an investment and return to the pockets of the shareholders and the company. And so that's understandable. Whereas patients, their goals vary from person to person. For one person, it's to lose weight. Another person is to control their blood pressure. You hope that their goal overall is to improve quality of their lives, but it may not be. And then finally, with providers, and I hate the term providers, I like physicians, but we have to look at the landscape now with mid-level and other clinical professionals. Providers is probably the most accurate term as a whole for this discussion. Their goal is to provide appropriate care at the appropriate time. And although I do spend time teaching our residents about the costs that they're incurring, my impression is that with most providers, their goal is to provide quality outcomes for their patients, and they could not care less about what that would cost an insurance company to get there, which then drives us into prior authorizations and all sorts of interesting conversations there. But
so let's lay that out real quick just to make sure. We have camp 1, that's the patient whose general disposition is to seek whatever level of care is congruent with their non-medical goals, right? Be as healthy as necessary to move on and do whatever it is they're about. We have the physician or the provider camp, whose job is to administer what services are deemed clinically appropriate, somewhat agnostic as the cost, at least for the sake of this model, right?
Exactly.
To the patient. And then you have the payer, who almost arbitrates between the physician and the patient, such that they're trying to, in some capacity technically, match the provider's clinical desires for the lowest cost feasible. But in practice, what ends up happening is lowest cost feasible amounts to do as little as possible to maximize profits for the shareholders. And we end up with the conflict of these three parties kind of vying collectively for the sake of a shared pool of phenomena. Is that correct?
Correct.
Okay.
And with that conversation, it often gets confusing even for us who are providers, because I admit I whine a bit a lot sometimes with my residents and our students, and saying, hey, does this company not realize that if they get the better treatment now, in the long term, that may actually reduce the costs? But I recently had this experience with someone that failed a bunch of treatments. So we said, let's try this new thing. And the insurance company said, well, no, you can't try this new thing yet. You have to prove that you've tried everything else. And my initial response was, well, wait a second. This is the best thing out there. It's the newest thing. It's modern. It's great. Or I could do OMT on this patient on a regular basis, and which would be less expensive. Would you want me to do OMT every week? Until I looked at the cost of the treatment. 1 month of this treatment, over $3,000. So OMT would actually be, even if I did it on a weekly basis on this patient, which it is indicated, would be significantly cheaper. So I had to step back and say, okay, I can understand why the insurance company who's paying for this patient to receive treatment would say, hey, now wait a second. Is $3,000 a month really indicated? Are you sure you've tried everything else? Because when they would go back to their shareholder and they say, well, yeah, we're paying out $3,000 for this, we're paying out $10,000 for this. That's what, I'm sorry, we don't have so much of a dividend for you this quarter. The shareholders are going to go, well, wait a second. If you can't provide value to me as a shareholder, why am I going to give you money? I'm not going to invest in you anymore.
And now we have the conflict between two completely, until this point, unrelated goals. The kind of assumption within medical work, clinical work, is that the mission is provide clinical outcome, right? If sick, then fix. However, in the business environment appropriately, again, for the way that these institutions are set up, you're not necessarily concerned with the product per se, you're concerned with the profit officially. So if you have a dope product, but the I say, if the business model is self-defeating, then it is fiscally irresponsible, right? You are doing a disservice in that goal set. So if you're playing the money game, which is a very fair game, right? Money isn't necessarily good or bad. It's another thing, just like everything else we have.
Right.
If we're playing the money game, you might have the dopest outcomes in the world at the cost of somebody else's bank account, which again, that's a genuine conflict between two systems. So let's play with all that. The game we want to do today, and the reason I wanted to kind of lay all that out is because there's a context for why we want to play the what would be better game. It has to be kind of built off of the what is currently there and why game, right? So once upon a time, AT still, gotta go back to that now.
Yep.
There's this idea that any old doc can figure out what is sick, but it takes true skill and and effort and work to find health. And it's been a very interesting, how many years have we been in this game journey trying to articulate the phrasing find health in a way that isn't either a cliche, lip service, or outright false, right?
As we would say, quackery, right?
Right. We had that podcast with the two other guys where we had this whole basically tirade, the four of us together, about how, osteopathy's claim to fame is essentially holistic medicine, but that word doesn't belong to us anymore. And we need to get over it and move on, right? It's what does it mean to find health in an environment where we have all of this tech and resources and knowledge, as opposed to, chicken livers and mercury.
And what does health actually mean? Does it mean, oh, I can get out of the bed in the morning? Or can I lift 300 pounds for the deadlift? Can I do my regular job without killing myself? I mean, what is health? That by itself is a nebulous, difficult to define idea. I think that complicates.
I guess that's the first level of this game then, right?
Right.
So perhaps, at least between you and I, we can come to now, to be fair, this game is stacked. I've known this guy for how long now, and vice versa. But for the sake of setting the rules of engagement, perhaps we need to come to a working definition on camera of what we'll call health, so that we can talk about what we're pursuing in a way that is objectifiable as opposed to purely abstract.
Absolutely.
You first.
That makes complete sense, because if we are truly going to develop a healthcare system, then we have to know what health is. And then on the second side, or the backside of that, is we have to know what care would look like. Because going back to this example that I shared, yes, there is the provider conflict with the payer, but there's also conflict with the patient. The patient's like, hey, I've been dealing with this for a while now. Can you figure something out for me? Both of you, can you just stop arguing and get treating? Because that's what I'm coming for. But the shareholders then are saying, look, if you can't provide us value, we're going elsewhere. And if they go elsewhere, where does the insurance company go? The insurance company goes away. And if the insurance company goes away, then that patient's not in my clinic anymore, because they can't pay for things. So it definitely is a complicated mess, if you will.
And we could phrase that two ways. We can go down pathway one and say the healthcare system is a Kafkaesque evil. That is a very reasonable read of the scenario, actually, right? The machine is inherently terrible. Tear it down, build a new one. Or in a less overtly negative sense, we can also frame it as the system is way more complicated than any one agent is willing to comprehend in isolation. And these barriers end up needing to be respected. Perhaps the reason why the system is so Kafkaesque is because it has to be, perhaps. Before we reject the premise outright, let's play within the game. And if we get to the point where we find that there is no solvable state, right? Let's pretend within the rules of engagement, there is no way to solve for this game. Maybe that is our technical proof of the system is down. Not to quote, Strong bad.
Please do.
There you go. The system is down.
The
So
system is down.
for all the times that song comes up in this house, that and Trogdor. But yes, we can burninate the entire healthcare system and burninate all the people, but that would probably be a bad business model. So let's try this. James, would you like to volunteer your first idea as to what health is? And then you and I just kind of bounce back and forth until we find something we agree with, so that we can agree that that's the thing we're building a system around.
Okay, so I would say health is not the absence of disease per se,
Okay.
but the maximizing of your internal physiologic systems that maintain allostasis, the state of being balanced, such that when the next injury or the next dysfunction that shows up, whether it be from infection or trauma, whatever that may be, the allostasis is such that it bounces back quickly from whatever injury may occur to the system. So I guess for me, the health would be the ability to maintain allostasis through any number of environmental changes.
Okay. I like that. I understood that. Explain it to me like I'm not me and one of our listeners. What the heck is allostasis, man? Like, dope.
So
I got you, but what?
You may have heard the term homeostasis, which is
Yes.
in a
Much more common
inadequate,
use.
much more common use, but inadequate for the description of our body. So, for example, we talk about what our body does with sugar when we eat it. And the whole purpose of insulin, amongst other things, is to regulate how our body responds to a sugar load. And you could say that there is a very damaging effect for sugar consumption. So if you have a single load, you've just had your first shake from a local shop in months, so you're not used to loading yourself with sugar, your body will spit out insulin, among other things, in order to maintain balance so you don't overload yourself. And so a healthy person can take that attack, that injury, deal with it in a positive way, get the sugars out of the system or put into storage, used for fuel or other things, without much of a ding to your overall health, versus someone who is normally consuming way too many carbohydrates, and now that regulatory system has been set off balance. Now there's no more storage location in the liver for sugar, so now you've got to store it in fat, and then the fat leads to hormone imbalances, and you develop long-term inflammation and all sorts of stuff. Then your allostasis is no longer possible, because your mechanisms for managing that, keeping everything back in balance, are knocked off. So it's like you've got a wobbly stool, and one of the legs has not just become loose, it's actually broken off, and so you've turned a four-legged stool into a three-legged stool, and you're trying to maintain balance.
Just to make sure I'm mapping it correctly, would, kind of riffing off of what you stated, would homeostasis be something like the state of maintaining some sort of whatever? The homeostasis would be the state of maintaining a thing, whereas allostasis would be the state of maintaining that thing in response to perturbation. Is that,
yes.
Am I phrasing that correctly?
Yes, any type of environmental insult. That's the word I was trying to think about.
Okay, because that does something interesting then, because now, if we take that as our working definition, or at least keep playing with that working definition, we have something like health is something like maintaining or otherwise improving one's capacity to handle the perturbations of the environment, or something to that effect.
Right. The ability to take an insult and keep on laughing.
Let's play this game then, because this would say a lot about how both of us will end up framing this. Is health, let's pretend health is a stat, like in a video game, that you can acquire. It's something you could level up or grow, right?
We're gonna buff our health.
Exactly. Is health asymptotic in its growth? As in, like, does it eventually cap off and there's a maximum amount of health a body can achieve?
Mm-hmm.
Or is it a linear thing? Or is it some other graphical construct that we can play with? As in, is it theoretically possible? Let's pretend perfect resources and infinite money, just for the sake of the concept. Is health something that we can, if work more and more resources grows indefinitely, as in, can we live forever? Or is health something that peaks off at some arbitrary level, such that there's a point where there's no such thing as getting quote unquote healthier? You've maxed out, quote unquote, whatever you got. Do you frame it more as infinite growth or asymptotic?
I would definitely say it's asymptotic with a vast majority of our patients. It would be interesting if someone achieved linear growth or linear, but then again, as you approach an outer limit, there's only so much more you can go before the body is like, okay, I've done. You see weightlifters have certain limits that they can get to, and they just can't lift anymore because they're physically not capable of building or putting any more muscle in place that would allow them to go higher.
I was going to say, in the strength and conditioning in the bodybuilding environments, we actually have a term for that. It's a genetic potential, which sounds about as eugenic as it actually is. But there's this idea that in a less, terrifying sense, for a given frame, like, look at how thick my bones are relative to my height, there's a certain amount of mass I'm physically capable of putting on before any more becomes actually, one, mechanically impossible without changing my underlying chemistry, hence testosterone supplementation and things of that nature, right? Like, I'm just gonna make up these numbers. This is me for a second, as a 5'4" Pacific Islander male with a wrist circumference of 17 inches, I can put on, I'm just making this up, screw it, 30 more pounds of muscle before I've hit the limit of what people of my size and demographics seem to be able to put before hitting that asymptotic curve, asymptotic point. Versus if I was a different ethnicity, a different height, a different bone density, et cetera, et cetera. Now, the interesting thing, which may be relevant to this conversation, is for the vast majority of individuals, they are so far away from their genetic potential that it is essentially linear. This is where the fact that we're on a Zoom call might actually be really nice. Check this out. Hold on. Okay, cool. There's a graph, right? And we're using a word, by the way, that not everybody may know. Asymptotic. That's a calculus word, and math makes some people's anuses pucker. So we should probably imagine a ceiling. Okay,
max.
This is not for this is for the listeners, not necessarily for us. Imagine a ceiling. Okay, and imagine a growth potential. Okay, my camera is now the ceiling, like here, top. Okay, so what ends up happening is, as you get closer and closer to the ceiling, look at the rate of growth here, right? Boom, like a little rocket ship. As you get closer to the top of your growth potential, notice how the rate starts to change and it starts to level off until eventually you're almost there, but you never quite touch it.
Yeah, you never quite get to max. And that could be determined by a combination of genetics and environment.
Even and labor costs, in all fairness.
And labor costs, the ability. Can you work out 2 hours a day? Or do you have a whole load of kids and a spouse, and you're limited as to what workouts you can do?
Right. It's the Hollywood effect, right? If I was paid to be this good looking, hell yeah, I'd do it because it's my day job. Versus, right, if that is an extra side gig, basically, to invest in myself at no benefit to anybody but myself, how much am I willing to invest in it to do so, right? Like,
absolutely.
A fun example of this, just to line it out, is okay, so we're agreeing that it's asymptotic, as in there's an upper bound technically.
Yep.
Unless we start getting into like cyberpunk turf, like meaningful diversion. One of the ways to change this curve, right? So let's say, boom, you have your curve and you're asymptotic, but you want to tick it up again like that. and keep it linear, one of the ways to do that factually is to dope on testosterone, right?
Right. Right.
However, that has consequences, like, consequences like cardiac issues, or
Cardiac
in the case of
issues, psychological issues,
exactly.
um, even other hormonal issues, voice changes, and the like.
Right. So like if we have a constrained value of health as your muscularity, no, we can actually keep it growing. But then all of a sudden it's like, yeah, you can grow more muscle, but now you need this medicine. How resilient are you? It gets more nuanced as you get that far. But an interesting thing is, and this is a good example of that genetic potential idea. So based on an app that I'm using, right? That whole AI digital coach thing that I'm playing with,
Mm-hmm.
I'm somewhere between 67 and 70% of my genetic potential as far as muscularity. Kind of dope. I was like, go
Cool.
me. Yeah. But the amount of labor to go from 70 to 71 or 70 to 72% is insane. The training is easy, right? 30, 40 minutes of kettlebell work of stuff that I like. My kettlebells are right there. If I move it right out of frame, there's a stack of iron right there. You know what I mean?
Yeah, and it's accessible, and it doesn't actually take a whole lot of time to
And I
add
do
some
this for
extra
a
kettlebell
living.
work. Yeah.
However, the amount of protein I need to shove down my face, forget the fact that it's a lot of just actual time spent eating. It is fiscally demanding, right? If I have to put down based on my mass and my training parameters, estimated protein intake for me is about 1.8 grams per kg per day to sustain that level of growth. You can do the
Mm-hmm.
math, blah, blah, blah. It ultimately ends up at I need to put down about 150 to 200 grams of protein on most days.
That's a
And
lot of
that's just
protein.
annoying.
And
So,
that's why people use protein shakes
right,
rather than just eating a steak.
right. So I might actually, as an individual, cap out at about 70 to 75% of my potential because I don't think I want to go further.
You do you need to go further?
Right. Like, do I really need that six pack? I don't know. But there's this idea,
Hey,
right? Like I'm hitting that point where it's no longer linear growth. It's gotten to this thing, and I'm like, the amount of labor to go from here to here may not be that much, but to go from here to here might take double of what it did to get from here to here. And all of a sudden, it's like, how long will it be before the amount of work to move the needle gets so much that it's no longer physically worth it to grow?
so taking that idea that the extra labor may or may not be worth it depending on the patient. So how do we make a system take that into account? Because
Okay.
currently the Medicare, Medicaid, they're trying hard. They're really trying hard with their wellness visits and their requirements. They're doing the best they can uh, to encourage some kind of outcome, although I don't know that it's all that well defined.
So let's play with that. Based Forget about all of the statements, the press releases, the stuff on the CMS page. CMS is the Center for Medicare Services. Just let's go just off of what they're actually doing. They encourage annual for the 65 up population, which implies a certain thing. So for the geriatric population, elderly folks, they encourage yearly screenings of various types. If we broaden out the definition past Medicare and include the USPSTF, that's the US Preventive Task Force, right?
Mm-hmm.
Then we can extend that idea to the USPSTF, which de facto will be the government healthcare standard, just to keep it really simple for those who are not in the medical field. For those who are in it, that's obviously not the case, but just keep it simple for a second. There's this idea that if you are doing your job, at the very least, you are screening for and preventing these various phenomena. If we go by that and what prevention means, let's categorize prevention into active versus passive. Like when I try to gain muscle, for example, that's active prevention of disease. We're assuming that by building up a reserve of tissue, God forbid something happens, my physiologic reserve can handle it. Allostasis, as you mentioned, yes?
Exactly. But by training out of frailty, you're building resilience into your system.
Okay, so that's we'll call that active prevention. The this other thing, which is not bad, I'm not going to denigrate that because it's actually a very good thing that functions almost as surveillance. It's more like a passive thing, right? We're not going to do anything to keep you from getting the thing. However, we're going to keep watch over you such that if you get the thing, we intend on catching it early enough such that it doesn't progress to a bad thing. For example, that tiny little fleck on your skin might be the beginning of melanoma. Let's chop it off now. Pretty valid. You know what I mean?
Yeah, a very useful prevention technique.
So let's play with that. For the record, there is no script for this episode. Anybody listening, this is us actually playing with ideas, which means it's a weird format for a listener because they're hearing us actually brainstorm as if it's the pre-recording on the recording.
Now you get to see what we're thinking. Yeah,
honestly. Okay, so let's play with that. If we're dealing with passive prevention, surveillance work, and that's what our system is built for and incentivized for based on the things we need to do to get paid, we can extrapolate that and go that the current medical care system, which is sick care but grafted on a healthcare like plugin, right? God, I'm using too much AI stuff. Anyway,
it's kind of like a fruit salad tree where you've grafted a bunch of different fruit into one tree stock, and there you go.
Right, you get the idea. But based on that incentive structure and what tasks we actually need to perform, it is something like the current system is designed to catch you when you're minimally sick to qualify for services to prevent you from escalating in your level of sick. So it's almost like if we talk about that curvy linear thing, right? Boom, there it is, right? It's almost like people live here, and if they were to slip down, our system is designed to catch them before they slip too far and keep them there. As in, our system's designed to not let you get worse if it works ideally, but it has no mechanism to help you get better.
Well, and there's no incentive, as we've been saying, but in reality, there's no reward for getting better.
Right.
When to compare this to auto insurance a little bit, there are rewards for being a good driver for some auto insurance companies, or you keep your rates lower if you stay out of accidents and whatnot. For health insurance, there is no reward for not using services, or not double negative there. Not using services, but not needing services. So how would we take the idea that you're building resilience, physical resilience, maintaining allostasis, thus providing less strain to the system? How would you even build an incentive model that would work for all three of our participants? What's that?
I actually have a terrifying answer for that.
Okay, let's go for it. Scare the audience.
Christ. All right, we're going there. All right, so preface, I read a lot of sci-fi. Okay, so last month I read a book, really, really cool book called AI 2041. So let me talk a little bit about that. Now it's like a book club. We're back there again.
Absolutely.
We're doing it. All right, so this is directly relevant to this conversation because the way this book works is a technologist, that's the fancy word for techno-futurist, guy who likes to philosophize about technology, okay?
Cool.
Work together with a science fiction author whose name is, I think, Chen Qifeng or something like that. I have his name right here because you guys might want to read this book. It's really good. Yeah, Chen Qiufan. There's no tones on this one. A guy named Chen, and the author of the other part is Kai-Fu Lee. Okay, so these two authors get together, and what happens is the technologist decides to play this game, kind of like what we're doing right now, of imagine the current state of AI. Fast forward 20 years. This was written in 2021 to 2041. Okay. Here's all the things we expect AI to be capable of doing based on current projections in 2041. Science fiction guy, I'm going to give you a piece of tech. You're going to write a story that outlines the narrative of what this tech will do. So, for example, one of the stories was something like Deep fake, which is essentially this technology where you can replace your face with anybody else's. Have fun with that.
And
Technology
voice
has
for
gotten
that.
that too, which is terrifying.
Mhm.
It's that kind of episode. Thank God we're not monetized, because damn. So in this short story, the deep fake technology has gotten so sophisticated such that all of the major governments, like first world nations, had developed legislation to protect themselves from deep fake. Great. However, the third world countries, in this case Nigeria, have not developed those protections. So now the third world countries who are tech enabled because we're in that phase of time, but don't have the regulatory bodies, are like dealing with the blowback of all this technology and no regulatory bodies. So what ends up happening is the author writes this really dope, like political intrigue thriller piece around this hacker who has to deal with deepfake tech at a very like nuanced level to navigate the plot.
Cool.
I'm not going to talk about the plot because that's the thing, but it's a
Right.
short story. It was like 2 hours. And then the next story is about like in Japan, this guy made a virtual game out of an AI ghost, blah, blah, blah. Okay, so all that to say, the very, very first story in 2041 might be an answer to this question in a not terrifying or terrifying way. So what they do is because of all the big data, smartwatches and biometrics and blah blah blah, it's 2041. People have like wearables all over the place, right? Imagine like Fitbit, but it's integrated to your everything. There's this idea that your insurance is tied to your social media, is tied to your, I guess, social identity, which is quantifiable via all this gadgetry. And based on your actual behaviors and habits and biometrics, your premiums that you pay for your health insurance change dynamically. It was a really cool idea that was obviously terrifying for reasons. And what ended up happening was something like this family had this son. So this family had pre-existing risk for diabetes because of family history, and their
Right.
son loves sweets. And then like the mom is kind of like, oh, honey, I got this great deal for this insurance provider because yay, hooray. And then all of a sudden they're like, oh no, our premiums are ridiculous because little boy, whatever his name is, can't stop eating Snickers. So they start like training the kid to stop eating Snickers, and he gets healthier, good for him. But now the kid's like, but I like Snickers. It wasn't actually Snickers, it was some whatever. But you get the idea.
Some kind of candy bar or
Right.
candy.
So like there was this behavior loop where because the poor behavior, that's how it's phrased here, was directly negatively impacting the financials of the family. Now they had direct financial incentive to actually get healthier in a very sincere way. The father in the story started driving like more safely, as you mentioned, with auto insurance.
Mm-hmm.
The youngest character, the brother character, ended up like losing weight and becoming healthier because mom made him, and he kind of like started to want to. The drama had to do with the POV character who, okay, all this incentive is great, but it turns out the idea of what is considered safe and unsafe is not calibrated for human souls. So like, for example, if you hang with the wrong crowd, as in if you make the wrong friend in your social media account, that's a high risk behavior, man. Your premium goes up. So all of a sudden it started off as a health app, and it started like infiltrating into like social engineering. And the story is told from the perspective of Indian caste systems.
Okay.
And it becomes this really, really cool navigation about the untouchables and the Brahmins, and there's a whole hierarchy in that one. But it ends up
Sure.
being told from the context of an AI system incentivizing healthcare behavior, all of a sudden turning into social injustice because they essentially magnify the institutional racism of a given culture. And I'm like, this is terrifying. By the way, what about those premiums? And if I have a
And
because
so yeah, how did that look for the folks who were not paying premiums because they're government subsidized?
say again.
How did that look for patients who were not paying premiums because they're government subsidized?
Oh, got it. So this story takes place in the Indian healthcare system. So they didn't have a Medicare equivalent. Like it was a completely different set of assumptions. So
Got it.
yeah. Like that sentence doesn't register as a valid query almost because of the assumptions of the narrative. That being said, they had an American version of the story, but that was more to do with job distributions and a bunch of civil protests, because turns out all the robots took our jobs. Get her done. You know what I mean?
Well, that's been happening since at least the early 1980s, so that's very realistic.
Yeah. So the UBI and like what to do with automation story, that went to the Americas. The healthcare story for this case went to India because it made sense for the sake of this narrative. But there's this idea there. Let's take out the fact that it went rogue and did bad things about literal racism. But there is an idea there that what if we got rewarded for something like your FFMI, your fat-free muscle index, right? What if the fact that my BMI is south of 30 was actually rewarded? Like, oh, wow, your BMI is south of a number. We should make you cheaper. Stuff like that. I don't know. It's an idea. Unfortunately, that's also tied to the presupposition that it's tied to insurance. Presupposition that insurance is even relevant for the conversation, right?
It goes back to, is there a need for insurance, or can the system be designed to not need insurance? Now, to say that can be cause for consternation from the insurance companies, right? Because they're saying, well, if you don't need us, we're going to go out of business, we're going to lose jobs. And the insurance companies, the insurance business is a big business that would have a negative impact across the US economy. So I don't know that we could actually say, let's get rid of the insurance companies, but how do we change the structures so that everyone benefits? I know there's a model out in California with a clinic, and we haven't really talked about direct primary care that much, DPC.
Which is surprising considering what you and I both wanted to be before becoming university docs.
For sure, for sure. There is a clinic in California that allows, what they do is for their paying customers pay a monthly fee to participate in the clinical care of this clinic. But that fee covers the cost not just for them, but for 2 other people who cannot afford the cost themselves. So they have become a self-funding charitable organization, charity clinic, that from what I understand thus far has been able to maintain operations even in the expensive California setting. So that is one idea people are using. The direct primary care model is a less expensive, more affordable concierge type of model. And I know the DPC proponents are going to cringe when I say that, but it does require a monthly fee as well as out-of-pocket costs for all patients. So that is one model to think about. I don't know if that's scalable per se. It works in that community.
Right. I was going to say, if there's a critical level of abject poverty, then the model is not sustainable, right? So like,
right.
if there's some magic ratio, I say magic ratio, if there's some unknown ratio of paid versus unpaid, such that the paid population can reasonably cover the care for the unpaid within a small bubble, then it's self-sustaining. But if the financials of that community change such that there's a threshold of those who are unable to afford, now the system begins to break down. And that matters because in a sufficiently affluent environment, that sounds amazing, actually. Hell yeah. But in an environment where the poverty is, let's say, ubiquitous and inescapable, let's call it a cyberpunk dystopia, because I just read Neuromancer, then
or maybe some inner cities that are currently dealing with stuff.
Exactly. Like, I don't know if there will be enough people who can pay into it to support such a thing. Hence why there's kind of a case for things like Medicaid, you know what I mean, and Medicare, because what do we do with the absolutely destitute or those who are unable to afford care in these settings, right?
Absolutely. And the question that comes to mind is, can we do separate systems similar to the National Health Service in Great Britain, which has both private medical systems and the nationalized health system? But we see that doesn't necessarily work any better in some ways than what we have in the States, although you could argue that some countries that have instituted similar systems have better overall outcomes. less maternal fetal fatalities, and longer lifespans in the US with fewer other issues. But the question always comes to mind for me is, are those outcomes due to the system, the medical care system, or are they due to environmental factors within the community itself? Quality of food, less work hours, reduced stress, more vacation time, all of those kinds of things.
That actually brings up a punchline from a comedian. I can't remember his name. There was something to the effect of, "You Americans eat like y'all got free healthcare." And I was like, solid burn, dude.
Oh man, that's the truth, and
Seriously though.
That's definitely an input we've talked about in the past, but not in this context of, hey man, what are you eating? What are you consuming? What kind of stress are you dealing with? And is it because you're working 50, 60, 70 hours a week just to make ends meet, and your job is not rewarding, and you're not doing what you dreamed about doing? You're doing something that rewards someone else but not yourself. All of those environmental stressors contribute to fragility versus resilience in our own health, and it throws our allostasis off.
So let's roll it back a couple steps, because I like the various threads we're throwing out there and kind of reeling in. So let's build a parallel system, just for the sake of the mind game, that is engineered to facilitate health. We're defining health as the ability to maximally navigate the insults and perturbations offered by the environment. That's both your food, your illness, your actual like environment in the macroscopic scale. And we're making the agreement that is something like, in order to maximally navigate the environment as such, you need two things. One is the lack of overt pathology, which the system's actually kind of built for. Good for them. But on top of that, there's this missing component of building resilience into the body. So in the context of building resilience, the problem is, one, it's not incentivized. Two, I don't know any procedures or interventions medically that create resilience, right? Like, I can give lisinopril to drop blood pressure 10 points, but I don't have a pill that can give me 0.5 gram more muscle per dose. Right. So maybe we cover that idea. What would it look like on the intervention side, quote unquote, of this system, right? What would we be doing as clinicians for these people who are trying to build resilience into their health?
No, I will give a shout out to Blue Cross Blue Shield. Yeah. Shock. I'm going to give them a shout out. With some of their programs, they do offer discounts to local gyms. And if you go to a local gym that's on their list a certain number of times a week, they do have a reward system. You can earn points, and those points accumulate until you can get stuff from their catalog. It's interesting. They limit how many points you can earn in any given year, but the catalog has some pretty cool stuff. So there is at least that structure available through some insurance companies. I don't know how widely it's used, and I would love to see data that would indicate it is actually productive. I will say, I've done a few things, recording things to get points so I could get free stuff, which, nothing is free, but it's stuff. And it did encourage me to at least keep a little bit better track. So there is always that ability to earn free things by choices you make.
I mean, that in essence is a less terrifying version of what I just mentioned with the 2041 book, right? It's do the right thing, get a chunk off your premium, or do the right thing and earn a digital cookie. I don't know, whatever you're about. You know what I mean?
For
Here's
me,
a
it
mug
was
that says you're dope.
For me, it was a hand blender.
And there you go. You know what I mean? But there might be something to that where goods and services may be rendered as a function of your effort to grow such a thing. And then they set it up such that there's an actual feedback loop of, I have this payer who will cover my risk, but in such a way that, in order to reduce my risk further, because there's benefit in that, if I were to elect in such behaviors and do it in a way that is demonstrable, then I can pay out in such a way that I get an actual product for it. Whether that product is a actual physical item or a service, that's up for debate, right? I went with
right.
decreased premiums for the sake of the story I was telling, but it could be a mug or I don't know, what else do people care about? You know what I mean? A necktie.
Electronics. You can
Right.
earn bicycles. You can earn all sorts of stuff. You can earn clothes, food, all sorts of things.
I was to say that, but that there's an idea there, because one of my friends, actually, close friend of mine growing up, he got a job working for a pharmaceutical company as he got a gig, basically his first like real gig out of like education.
Mm-hmm.
And it was just a really cool conversation, because it was kind of like, yeah, man, I got health insurance and now they cover all these gyms. And it's kind of like, yeah, this gym now is free. And this used to cost me blah, blah, blah. And now that I have this, I'm going to hit the gym because I can afford it. And I'm like, good on you. Shit.
Yeah, you do it, man. You do it.
But it was so interesting to hear that, because
that is definitely an interesting perspective that, you're already paying premiums. Now they're going to cover gym memberships. I will tell you that I have sent many of my patients looking into their silver sneakers benefits from Medicare, because it does cover the cost to some extent of gym memberships in participating gyms. So
now there's an interesting construct happening here that we should bring to attention then. Watch this, everybody. If we start the game off the current sick care system, right? Let's take point 0 as a healthy individual of middle age. Okay. In order to get them minimally not sick, a effective clinician or public health provider of some sort, primary care provider, will do all the necessary screening things. Do I have insert set of diseases? Answer equals no. Congratulations. But that is not the same as developing resilience. That's not the same as developing the capacity to actively prevent disease, right? I don't have disease yet, but is there anything I could do to not let it happen? Okay. So we're saying that we incentivize people to engage in behaviors that would actively prevent multiple chronic diseases relevant to our population. We're kind of building in as an assumption here. It's obesity, diabetes, low back pain, technically cancer, etc. Right? So the proposed intervention, because there ain't no pill for this, is we kind of jumped to, it's probably going to be in the gym. Okay. There's a bigger assumption there that and this is something I think we've stated this explicitly a couple times, but it's becoming ingrained into the structure of what we're saying now. It's this idea that the opposite side of medical services is the health and wellness industry, right? Like sick care, the present day sick care and the present day health and wellness industry kind of live on opposite ends of the same set of tasks, right? You're sufficiently sick, you're a medical person. You are sufficiently healthy, you're a health and wellness person. The health and wellness people are actively trying to not fall into the sick place. And the sick folk are trying to get healthy such that they no longer qualify for sick care. And if they so wish, they can pursue greater capacity in the health and wellness space. Is that construct what we're going for right now?
Yeah. So right now, they are like neighbors across the street that wave at each other as they go to and from their homes for their daily activities, but rarely spend actually any time together.
Interesting, because that leads to a very high level observation that in this theoretical system, right, we talk about like having a medical home, right, as far as primary care, Medicare, blah blah blah. There's this idea that once you escape the orbit of needing medical services, the next step is something like a physical culture. Like I'm trying to think of Once Upon a Time is an old black and white film of like, it was like the John F. Kennedy athletic something for high school. this is defunct now. We don't do this anymore. But there was like it was this really cool black and white footage of a bunch of high school kids just doing calisthenics as
Right.
part of their basic PE. And I was like looking at it like these kids are doing basically CrossFit as part of their gym class. And I'm like, this is amazing. And this was like a national standard to some capacity. Or at least the way the video framed it, it was a national standard. But there's this idea that in order to make a healthy, young, strapping population for war, because what do you care about in these videos? You know what I mean? There's this idea that if it is not enough to just be not sick, you must also be physically adept. And in doing so, they built it into the high school system in, you know, kind of golly-wish quaint Americana.
Well, and I think this is a good place for us to pause the episode and put a
To be continued.
To be continued. I would like to spend the entire next episode talking about physical culture and how that can contribute. So what do you think
I'm
we
gonna get my strong
segue?
shirt.
That's right. I need to get one. Yeah, absolutely. So let's pause there as and end where what we're doing tonight, and we can go on to talk about physical culture at the next episode. What do you think?
I'm down for that.
All right. Well, thank you for joining us with Roland Bones, the Osteopathic Podcast. As we do this long form technique and approach, we're going to continue on this discussion on our journey to find the healthcare nirvana.
I say this isn't find it, fix it, leave it alone anymore. We're building a new dang thing now, right?
Right. We're not sure exactly how everything's going to look, but we're going to build a new invention. How's that sound?
There you go. We will find it. We will find it.